Now we move to an important moment in this meeting. Dr. Sionis and I have a great pleasure in introducing the first Magda Heras conference. Several speakers could have been chosen, but for us, it is a great pleasure to have Dr. Valentín Fuster as the first speaker. Magda worked closely with him, both as colleague, as a friend. Dr. Valentín Fuster doesn't need any presentation. The most important thing for us is to listen to him. And his topic this morning is subclinical disease of the heart and the brain, a challenge of the decade. Thank you for being here on this special day.
Well, thank you very much, Rosa-María, Alessandro, colleagues and friends. I will say from the beginning that in our walk through life, we meet many people who cross our way, hundreds of people, all of us, but there are very, very few who really have a permanent impact on us. And in this case, there is no question that Magda has impacted all of us. Now, Magda was a very fascinating person who I met in a very rigorous way as a scientist. And this actually was in 1987, 1988, and 1989, where together we had a number of projects, and she was in the United States. But her rigor was also present on many other aspects. For example, I think it was in 1997 to 1999, I had to talk to Magda many, many times, and the reason was the Journal of the Spanish Society, which had to be recognized officially and internationally. And I remember we worked together until the process actually completely succeeded. Well, she was very rigorous, but we were also rigorous to the point that when one of her colleagues, Ginés Sanz, who did he spent a very successful time in CINIC in Madrid, decided to retire. When Ginés decided to retire, we said the ideal person to take over the job was Magda. And actually we contacted Magda, and we both were so excited because she was going to come to join us in the National Center of Cardiovascular Investigation. And the problem, obviously, it came a few months later. She, I would say, was a fighter, and was a fighter for the truth, was a fighter for the best. So this is actually the title that I would like to, at least for you to remember, and this resilience. Resilience is a fighter, mental, physical, and moral. And I must say the family here today, Mark, the daughter Anna, and the sisters and the rest of the family, I'd like to tell you that will be very, very difficult, impossible to forget Magda. And for me, it's a real pleasure that giving me the opportunity to make a presentation this morning in honor of Magda. Thank you very much for this opportunity. Well, what I'm going to be talking about is a little bit futuristic, and is the question of subclinical disease of the heart and the brain. Can we identify who is developing the disease and doesn't know? And if so, is going to change behavior once this is identified. There is a second title here, which is resilience again, but I'm going to be presenting today 3 problems that we have at the present time. And this is how I will begin my presentation. And later on, we are going to go into the 3 main challenges that we have in the future. So let me begin by presenting to you what really should worry us. And I'm just going to concentrate on the left part of the slide. Here you have 3 aspects. Let me tell you that this is actually the first one I will be discussing, and that is the significant change that is taking place today in moving from cardiovascular disease in the elderly to promoting health in the youngest. Then we have a problem with the world of consumption, the environment. We have a problem with air pollution. These issues have to be discussed before I really get into the challenge of subclinical disease. And let me begin here with the change that is taking place. No question that we have done reasonably well in the field of cardiovascular disease. Actually, life has been prolonged 6 years in the last 3 decades. And it's interesting, about 50% has been through changes in the public arena, and 50% has been to treatment, to the management of complex coronary artery disease, particularly the use of defibrillators, better treatments in heart failure. And the result is that we are doing very well. But the problem is really obvious. If you just concentrate in the United States, and I don't think it's different than in Spain, if you concentrate in the United States, today in 2016, the cost of treatment, the second part I mentioned of cardiovascular disease, is $300 billion. And it's increasing. And this will not be affordable. In a matter of fact, all the economists know this, and the politicians are very afraid to talk about it because it seems you are talking against the public and the interests of the public. So it's something very subtle, but it's something that is very impossible to sustain. So this is a first problem that we have to fight. How? We have to move earlier and earlier in trying to identify people who have the disease, and maybe we can do something about much earlier and less costly. The second issue is the one that worries me the most, and that is, what are we doing with the world of consumption? And that is, are we changing our lifestyle? Very little. In fact, I'm going to present you information, and I decided to choose just cigarette smoking. I talked yesterday, I was in London, and actually my presentation was very similar, but at that time I talked about blood pressure. We have a huge problem. If you look at what are the risk factors that kill people today from the cardiovascular point of view, first has to do with diet, blood pressure, and here you have tobacco. Now let me present to you, because this is something I know, how tobacco has been approached in the last few years, and is dramatically frustrating. Let me begin by saying what we are talking about. Tobacco, here you have great success when Framingham in the 1960s says tobacco is bad for your health. In fact, the first finding was in cancer of the lung, was not in the cardiovascular field. And then what happened is the first Surgeon General report came in the United States, this was 1964, and had a significant impact. It was like a discovery. Everybody thought this is important. And the incidence of tobacco smoking significantly decreased. And here is something that I don't think anybody can forget. People who start smoking in adolescence, life is shortened by 10 years. This is United Kingdom, men. This is the United States, exactly the same. And these are actually women. So basically, if you do not stop, you can be assured that life will be shortened. What is interesting, if you stop smoking at an early age, you might gain the 10 years again. But if you stop smoking at age 40, you might gain 6 years, 5 years, so you gain. So there is some benefit by asking people to stop smoking. And I'm not getting now into the passive smoking. This is active smoking. What is interesting in the last few years has been how smoking works. What is the problem? And I can only say to you that nicotine is one small part, but there are many particles in smoking that really can affect you. The nicotine actually stimulates the sympathetic system, can be tachycardia, vasoconstriction, hypertension, but the main problem probably relates to oxidative stress from the products of tobacco, oxidative stress that gets into the circulation, affects the endothelium, affects the clotting system, and we have a product which is toxic. Oxidative stress is probably the most important pathway. And you might say, and so what? Well, let me continue. What progress has been made in tobacco? And this is the dilemma. The whole thing started with the United Nations in 1992. They decided we are going to kill tobacco. And then all these people got together and decided to really fight tobacco. 1992, results on the right, all quit in the following 6-7 years. They said, we cannot fight industry. Failure. In fact, everyone had a point. The only one that really has sustained is civil aviation. You cannot smoke in the planes. That's the only one that actually has been prevailing. All the others were killed. With this, the WHO decided in the year, I think it was 2003, to really fight the industry. And the way they did it is they put 177 countries together, and we are now going to fight industry, and we will win. This was actually advocated by Harlem Brundtland, who was the chair of the WHO. Results. Today, only 35% of these countries are following the mandate of 2003. All the others quit. They decided they could not fight industry. Now, this is the story of tobacco today in 2015. This is China going up. And you say, success, very little. It's true, this is actually United States, Australia, and some western part of the Europe, in which it has been some decrease of tobacco. But when you look at the whole situation, it's one of the main killers today. Let me tell you about industry. The industry of tobacco is incredible. They have the whole legal system that can always win, with the freedom of expression, with the concept of democracy, with the concept everybody is just can decide whatever you want, and they go legally again and again, and they are always winning. And the concept is there is a need for monitoring, exposing, and addressing the aggressive tactics of the companies. But here's the story. If you smoke today, the cardiovascular effects will be in 30 years. So what is happening is the problem of the epidemic of smoking in terms of impact is beginning. And this is something we all have to be aware of. We all talk about people smoke less and less. It's going to be more and more heart attacks because it's the smoking that has been going on that really leads to a problem in a few years. But this is an issue in society that is us. It is the routine, everyday nature of tobacco that makes it so easy to ignore, since this is every day. But I'd like to give you a few figures that make you to tremble. Amputees are a terrible symbol of war, but more soldiers actually lose their legs to cigarettes than to bombs from a hostile army. Now on the top, Ebola in Africa, as you know, in the last year killed about 10,000 people. You know how many people died in the world of smoking? 10 million. Now let me go to the bottom. The cigarette toll is more like 4 fully loaded Boeing 747s crashing every day. And this is just in the United States. I only present to you something that we are absolutely passive. It's like we accept it. And we say, and you hear, yes, smoking is decreasing. I show you the figures. It's a problem. And the toll is going to get worse and worse. And my question is, what are we doing here? Are we responsible? Or we need to be educated in order to react de novo? How the general, when had the manifesto in 1964, maybe we need a shake-up, but this is really a great problem. And we have to change tactics. And now is my real worry. These are all the risk factors, and this is what has been published in the last year from the WHO, the World Heart Federation, and the American Heart Association. And this is that by the year 2025, we will reduce death related to cardiovascular disease by 25%. Actually, I read an article from the WHO a week ago that said by 2040 will be 40%. So what we do is we pick up a number and we say what we are going to do without a method of how this is going to be achieved. And I really ask you to look at how this will be achieved. It's a joke. It is all theoretical of people who don't see patients. Actually, they all sit in a desk. And they are making the 2025 an issue. It's very worrisome. We are in a very irresponsible society, absolutely irresponsible. I had the chance to know Bloomberg in New York. And what is interesting about that man is completely different. What he has done in New York is amazing. First, $1,000 penalty to the restaurants that have trans fats. Second, smoking has decreased by 50% during his tenure. Third, the first individual in the world that has been able to pass a bill in which individuals under the age of 21 cannot smoke. And I could go one by one. And I think this is the actual issue that I want to finish this part. And that is, there are two ways to me that we can move forward. One is operational, like Bloomberg is doing with tobacco. The problem with health and with global health is that there are very few doers and there are lots of talkers. Everybody talks about it. The governments, the politicians, everybody talks about it, and you do nothing, absolutely nothing. And I'm presenting you an example. Yesterday I talked about blood pressure. I could give you a very similar story. Here you have, no question, increasing tobacco taxation, particularly in poor countries, is working. Creating by law smoke-free environments, health warnings and mass media campaigns, banning all forms of tobacco advertising. This has to be done at all levels and certainly at the local level. But I think, and this is actually what Bloomberg is doing, but I think there is something to me much more important. I think we should take health seriously and not just deal with a single factor. This is actually health. Less and less people smoke today in the United States. But this is the problem, for example, of obesity, worse and worse. And these are the other risk factors. I think, frankly, that the answer to all these problems is that we begin to have a consciousness that it is a package of risk factors and is not the one that is leading to the epidemic. So I just presented to you two issues. We have to move towards health at much earlier stages and identify people. And the second, those who have the chance to dictate policy, they should wake up and begin to take things much more responsible. And this is what point I wanted to make. I'd like to make a final point. I didn't have any idea until recently when I was asked to make a presentation in London in the European meeting in September. They asked me to talk about a very important subject according to the committee, scientific committee, which was air pollution. I said, I cannot talk because I know nothing. Doesn't matter. You should talk about it. And I said, but I am against talkers who do nothing. And we had a correspondence that was quite fascinating. And what they say is, you will wake up, and maybe you will make to wake up other people. Well, I will tell you the summary. Unbelievable. We are so ignorant. These microparticles that are in our environment are as bad as cholesterol or worse. If you really look at the data in the last 5 years, it's a full literature. And these microparticles, what they do, get into the lung, and it's like smoking, actually. What you do is you develop free radicals and oxidative stress, and all circulates in the endothelium is being damaged, arrhythmias evolve, and this is we are here talking, I don't know about what. We have a problem. And what I'm here is to tell you that it's better we begin to learn what is wrong around us and begin to be responsible. Well, this is an issue. I stop now talking about resilience or what we should fight today, the three aspects I just mentioned. Let me now move into the challenge, and the challenge is the following. I took a topic, and the topic is if we are able to identify people early, those who are developing the disease, maybe we might be able to incentivize society to change their lifestyle. That's basically the concept after what I presented to you. It's more individual, it's more to the person. Well, let's begin by talking about the elderly. First of all, let me tell you one of the problems that I have seen. All of us talk generally. People should eat better, trans fats in the restaurants, stop smoking. Do you know, one thing we have learned in the last few years working with different ages is not the same when you talk a 16-year-old that if you talk to a 70-year-old. The perception is quite different. So you have to use completely different tools. But the tools have to be related to the signs of that age. What is the problem? And this matching is very important, and to me is actually one of the challenges. Let me start with the elderly. And the question is, we are not presenting here a patient in cardiogenic shock. I am presenting to you an individual who is losing memory. Something is wrong. I don't remember even the name of my wife. Well, this is pretty bad. Or maybe I have seen somebody yesterday and I don't remember who was. I read a newspaper about 10 minutes ago and I don't know what I read. If you talk to your patients who come with a cardiac problem and you ask about this, it's so common. And the question is, what is going on here? Are we paying attention? We don't. We say, well, this is physiological. Most of the time it's physiological. But let me now present to you the issue. And this is the problem and the challenge number one, is the microcirculation of the brain. And what I'm going to be presenting to you are 6 studies. I don't present ever anything that doesn't have a reference, and my friends know about it. I don't want to say things that come out of the blue. This is very solid, the data that is evolving. And the data that is evolving is the same risk factors that are affecting the large vessels affect the microvasculature of the brain. And I will be presenting these on 6 studies in the next few minutes. So that's the challenge number one. Do we understand the microcirculation? Do we have technology to understand the microcirculation? Do we have technology for cognitive function? Do we know what we are doing when we face these people? This is the issue. The microvessels occlude, and this is a lacuna lesion that you can see with MRI, and you can do perfusion imaging, and you can see a decrease. These are the papers. There are at least 30 in the last 2 years, but these are, to me, the most important. The first two relates to vascular disease in Alzheimer's and vascular disease in non-Alzheimer's. And the first paper actually is a historical paper about what Alzheimer's wrote over 100 years ago. And the second paper in the New England Journal is more recent. Then I will talk about the autopsy data, then about the relationship between the risk factors, imaging, and cognitive function, and finally, once we have the situation, intervening, can we stop the progression of the disease? These are the issues that I'm presenting. This is Alzheimer's. Alzheimer's says that his disease was vascular. Very interesting. He didn't think about all the parenchymal stuff that we talk about today. And in fact, these are two pictures. He says there are two types of vascular disease, and I don't know what these are. This is actually amyloid in the vessels, but this is what I'm talking about. He didn't know, but he wrote about it. Very interesting. And then the second paper in the New England Journal puts together all the literature and makes a very interesting comment that ischemia affects 60 to 90% of patients with Alzheimer's. In fact, what we are learning, and we have a study going on now on this, is Alzheimer's is a very complex disease, but the acceleration of Alzheimer's has a lot to do with the risk factors I mentioned, aside of the amyloid in the vessels. Well, then comes the pathology. There's so much information. I just particularly like this paper because it's very well done. And basically what happens is the microvasculature and the lesions as a result are very close together. Is this atherosclerotic disease? Actually, it's not. Basically, the endothelium is affected by the risk factors. This is an intimal hyperplasia. And the intimal hyperplasia actually closes the vessel. There is no cholesterol deposition. I'm just saying, it all happens in the microvasculature, but probably the protagonist is the endothelium under the risk factors that we are mentioning. This study is the Cardia study. 3,000 people that were seen 25 years ago, and the risk factors were all tabulated. And they followed 25 years later cognitive function. What happens if your blood pressure is not treated? What happens if the diabetes is not treated? What happens if the hyperlipidemia is not treated? And the tests that were done were the most recent tests. This now cognitive function has been standardized. Up until 4 or 5 years ago, everybody used different tests. Today is all standardized. Well, they use 3 tests of cognitive function and are here. And here you have, if the systolic blood pressure has not been treated, rather than having the data going up, is going down. Cognitive dysfunction with the 3 different tests that are being done. This is diastolic blood pressure. This is actually blood glucose, diabetes, and this is actually cholesterol, less striking. So what we did is the other way around. We look at the imaging. What they did is only look at the cognitive function. And this is the paper that we pulled things together, pointing out that most likely, the lesions that I mentioned to you is what causes the cognitive dysfunction. There appears to be no other association except in Alzheimer's, in which the issue could be different. And this led us to develop a study that is a transatlantic network study, which is actually with non-invasive technology, in trying to understand part of the study, the brain of people. And that is people who, for example, have disease in the large arteries, calcification of the coronaries. We will look at the brain to see if there is correlation. And people who have degenerative brain disease, we do the studies of the large arteries. This is the study that we are performing now at the present time to really understand the relationship that I am mentioning. I think there is some hope, actually. There are 2 other studies just recently that actually validate the finger study. This is from Finland. And very basically, they all feel that what I am talking about is real critical. So they put it together 1,200 patients with degenerative brain disease. And in one group, they treated them very aggressively. LDL cholesterol, less than 60. Blood pressure, less than 120. Smoking, no cigarette, etc. And then what they did is cognitive therapy, the combination of both. And what they found is there is a little bit, this is the cognitive function, of decrease of the progression of the disease from the cognitive point of view if you take care at that point. This is only 2 years of follow-up. So, in summary, we have in front of us a situation that is critical. Cardiovascular disease mortality is decreasing, and we have done a great job, but we have 2 problems. At an exchange, it's getting very, very expensive. At an exchange, we are prolonging life, and I'm not entirely sure how the brain is working in terms of prolonging life. These are challenges. And I think what we have to do is to start studying the process of the brain, how the risk factors affect this. Can we modify, as the Finnish group is doing? And this is a huge challenge. So this is not a superficial topic. These are the patients that we see every day, and many times we do not ask. And I think this is very critical. I'd like now to move into younger age, which is subclinical disease, but now we are talking about the large arteries. We assume that between age 25 and 50, maybe some disease that is not manifested clinically. Here, what I expressed in the last few minutes is just the challenge of degenerative brain disease. We don't know the denominator of degenerative brain disease. How many people with degenerative brain disease, the problem is vascular? I personally think, based on all the information that I have, more than 50% related to the risk factors I mentioned. Let's now go to a younger age. We have 3 studies involving 12,000 people. All these studies, one in Madrid, one in Zaragoza, and one in the United States, are people who never had evidence of cardiovascular disease, but we began to do imaging technology. Among the tests that we did, we have 3D ultrasound of the carotid arteries and more recently of the iliofemoral arteries, looking for focal disease, and the other you know well is calcification of the coronary arteries. What is the beauty of this is you have 2 different regions with 2 different technologies, and the question is how they relate to each other. The questions that we have are here. First of all, if we study the burden of disease with these technologies, how much disease is there? Subclinical disease, can we predict events better than by any formula, Framingham, European, whatever formula it is? Probably, because the disease is already there. It's like a bias type of a study. You are already looking at people who are in trouble. So in a way, it's a selective group. Well, this is what we found, as I will show you in a moment. Second issue is the economics of this. Can you use imaging technology that nobody can afford? Absolutely not. But I can predict to you that, at least in the United States, in the next 5 years, calcification of the arteries, of the coronary arteries, and ultrasound of the carotids and iliofemorals will be $20. I can tell you this right now, because I am dealing with the companies. I don't know what's going to happen in Europe, but at least things will begin to evolve in a way that will be affordable for people that otherwise this would not be affordable. This is the data. And you see, very interesting, in the first study that I mentioned was actually the HRP studies, United States, 6,000 people, no evidence of cardiovascular disease, and more carotid disease that you see here towards the right, more and more calcification of the coronary arteries in the vertical axis. The disease is systemic. This is very important, because in the future we might go to any region, and if the disease is there, we can predict it will be systemic one day, will be somewhere. What is interesting in this study, now we are pulling this together in a paper, is the large number of patients. There were, I think, more than 200 events. I will show you this in a moment. We have patients with significant carotid disease who develop a myocardial infarction. And we have patients with significant coronary disease that develop a stroke. It's a systemic disease. So those of you who are working on the vulnerable plaque, better you start thinking what you are talking about. Because there are so many vulnerable plaques. Actually, the disease is systemic. And it's very difficult to try to find out a plaque that is going to kill the patient. If you're an interventionalist, you may find a plaque that is bothersome. You may use some pharmacology, and to change it, you may contribute to the field of pharmacology. But I don't think you're going to convince me that you're going to really tell us who is going to have the event and where. But certainly, pharmacologically speaking, this type of intravascular imaging not only is how you put the stents, but may be interesting to see if you modify the plaques that you see. But that's not what I'm talking about. Do you know how many people in this world have a cardiac catheterization study by which such imaging technologies would be available? 1 in 1,000. So if you really have responsibility for the world, you are not going to start imaging arteries that you only pick up 1 person out of 1,000. You have to use technologies, non-invasive, that have much more impact. This is the first finding. And the second finding is more and more focal disease in the carotids, more and more calcification. The burden of disease was better predictor than Framingham of what was going to happen in 3 years of follow-up. There were 216 events. And basically what happened is Framingham looks at the long term, where these technologies that I'm talking about, they are already identifying who is in trouble earlier. And the question is this person going to change behavior? According to our data in the United States, it's not. And this is one of the problems that we have in society, and that is we don't feel vulnerable, even if we show the arteries. This is why the adherence to medication is so poor on people even who have coronary disease. If they feel well, I feel well. So there's a huge problem in the society that we live that, to me, is one of the reasons why we are under an epidemic, is because we don't feel we have a problem. And here is one example. Then we decided to go to younger people, and this is Madrid. It's the study we are doing, the PESA study. Antonio Fernandez Ortiz is the principal investigator. This study is interesting, is with the Bank of Santander, and we are learning a lot. Are also about 6,000 people. The study is more sophisticated than the one I just presented, but I don't want to spend too much time, but just give you a sense that we have a problem. In this study, and I don't think it's different, it's not because it's the Bank of Santander, I think it's all over the world. Here you have people that they are age 50 to 54, never a cardiovascular event. Can you imagine? 1/3 males have already focal disease in 4, 5, or 6 regions of the 6 that we do. 2 carotids, 2 iliofemorals, the aorta with 3D, and then the coronaries with calcification. And then about 2/3 have already focal disease. And look, women are younger. This is why women are less than men here, but then the thing crossover. This is what we have seen in the HRP study. Half of the women have already 2, 3, 4, 5 regions with focal disease. Intimal medial thickening, please forget, don't use that terminology. It doesn't work. It has some degree of validation of prognosis, but no question, quite different than when you look at focal disease. It's a different disease. And this is actually the study in Zaragoza, which is interesting, without going too much further. These are younger people, and what happens is they are not events. So what we are doing is correlations, and following is a long follow-up. And what is interesting here is if you increase the calcification more than 1, and here is more than 300, and here you have risk factors only, risk factors for carotid plaques, risk factors for femoral plaques, and risk factors carotid, you increase the prognosis. So basically what we are seeing is imaging is quite helpful altogether, is added to the calcification that is imaging, the 3D ultrasound, and maybe added to Framingham. I think we are entering a new era in which, by having this technology affordable, we will be able perhaps to have an impact on people to change behavior. And we are doing PET and MRI in these individuals, in the PESA study particularly, to look at the MRI looking particularly at the position of lipid material, and PET looking particularly at the inflammation. The exciting things about this is that when we are fusing both technologies, you can begin to see both the lipid material and here in yellow the inflammation. But what is most striking, and this is actually going on in New York, is we are beginning now to see activity in the coronary arteries. This is just with PET, inflammation, and it's fascinating. Here you see it. Okay, and in the carotid arteries. So we are entering an era on the issue of imaging that not only we can see anatomy, but we are beginning to see physiology and activity. And this actually leads to the next question that I'm going to be addressing, which perhaps is one of the most interesting ones, and is the microcirculation. I'm not talking about the degenerative brain disease, I'm talking microcirculation in general. Because we are now with imaging, we are beginning to get into this. I just want to start by making few points about the famous study. The famous study, as you know, looks at ischemia, and to make the long story short, although is a fractional flow reserve, is no flow, is pressure gradient between a dilated peripheral artery and the coronary artery in the distal to the obstruction and proximal. And if it is a ratio of more than 0.8, we say don't touch the patient. And if it is a ratio of less than 0.8, probably this patient should be revascularized. This data, I'm not going to go into too much detail, except that it's beginning to evolve as a very important aspect, and that is to revascularize not the anatomy, but to revascularize what we call is the physiology. But here's the problem. The problem is, how do you know what goes on in the very distal circulation? And this is the microcirculation. You don't have any idea. You do an FFR, and so what? You are looking at a lesion distally and proximal. But what goes on in the microcirculation is huge, as I am going to be presenting to you 9 studies in the next few minutes to realize that we have a huge issue that I think is quite important. I could go into great detail, but just to tell you, Hector Buenoacho is working on this field. It's fascinating. Do you know how much microcirculation we have compared with the large epicardial arteries? 100 times more. So if you really look at surface of the vasculature, the microcirculation is huge. And I think this is the first question that we have to be aware. Have we been able to address it? Absolutely not. I mean, there's been a lot of theories, but has not been addressed properly. So I'm going to present to you evidence, clinical evidence, that this is important. And the question is how we address it in the future. Before I do that, let me use technology to start with. What technology we have available that may begin to look at the whole situation of the microcirculation and the stenotic lesions proximally. Before I go any further, let me talk about the microcirculation for a moment. Basically, we know a lot about the endothelium, nitric oxide, preserving normal parenchymal function. The great problem, again, are oxygen species, free radicals. This is a very bad pathway on every aspect in the cardiovascular system. Because when you have these, there is vasoconstriction, there is fibrosis, and there is a problem. And you know, oxygen species is very typical in obesity. It's very typical in cigarette smoking. It's very typical in diabetes. All the risk factors I mentioned, now that this is measurable, is very significant. So now you are beginning to understand why we see so much trouble when an echocardiographer comes to us and says diastolic dysfunction, the patient is diabetic. Diastolic dysfunction, the patient is hyperlipidemic. Diastolic dysfunction, the patient is hypertensive. I'm just giving you what is evolving at the present time, which is quite fascinating from the chemical point of view. Having said that, first technique, positron emission tomography. I'm not going to go into the details, but here you measure flow, proximal and distal. You cannot say specifically whether it's microcirculation or not, but at least entails the microcirculation. The second, which is the one we are using in New York, is actually MRI. And MRI, particularly with injection of contrast, and we'll have more to say in a moment, and that can look very specifically to the microcirculation. The third one, which is to me quite fascinating, is CT angiography. Why? I will tell you why. Because CT angiography not only tells you the anatomy, but we are now, at least a number of us, interested in the field to begin to measure the FFR with CT, so that you might be able in the future, without invasion, to have the anatomy that you need to do in the FFR. And in addition, we are now getting distal into the microcirculation. All of these are techniques that are evolving. Let me now present to you the 9 studies that will convince you, I hope, that we are dealing with a huge elephant in the room. And this is the microcirculation. In fact, the trigger of all of this, in our case, was the Freedom trial. We were doing the Freedom trial, and we began to see that the patients who were revascularized with diabetes had as much angina with saphenous vein grafts than those patients who had stents. That was the trigger. And we say, we have a problem. We are revascularizing the large arteries, but we have a problem with the microcirculation. This is what really captured our interest in this field about 3 years ago. Here you have first a study in which you have calcification 0, means probably there is no coronary artery disease, but CFR less than 2, which means microcirculation. And this is adjusted MACE. This is a study much better because here is coronary angiography from the group at the Brigham and the group in Dallas, in which what you have here is coronary artery disease. The epicardial arteries are normal, CAD is negative. The patient is diabetic. The CFR is less than 1.6. These are the cardiovascular events. Here you have studies that we have been able to reproduce, actually, which is with MRI. This is what we are doing, which is latent gadolinium enhancement to see what goes on in the microcirculation using adenosine at the same time. And here you can see if there is microobstruction, the number of events is much more significant than if it is not. The number 4, this is the study that really led us to get into business, was the FREEDOM trial. And this is the data on the FREEDOM trial. On the left is CABG, 1 month of follow-up, 6 months, 12 months, 24 months, 48 months. And on the right is PCI, and this is actually angina, was the same. The diabetic patient has microvascular disease. And one of the issues that we learned is we keep telling the patients who were in FREEDOM to come back to do another angioplasty or an OM1 or a diagonal, and the patient continues to have angina. That's what we saw. This is the microcirculation. It's all in front of us, and we begin to do interventions of arteries that have nothing to do with the syndrome that the patient presents to us. This is the 5th study, which has to do with blood pressure. Drop of the blood pressure in the diabetic patient, which is very significant, probably following the on-target study and data that now we have in FREEDOM, we have significant number of events. Why? We believe because the microcirculation is affected and we are dropping the blood pressure too much. The next one, which we also saw in FREEDOM, is the hemoglobin A1C. If you have a very high hemoglobin A1C and you are aggressively and dropping the hemoglobin A1C down, you get a lot of hypoglycemic reactions. Catecholamine is released and the patient is in trouble. We believe that the microcirculation gets constricted by being too aggressive on a patient that is vulnerable because the microcirculation point of view. Here we have the study that we published not too long ago with insulin. There's a lot of data insulin affecting the endothelium, and this is in the FREEDOM trial, where we saw that patients who were in insulin, whether it was PCI or CABG versus no insulin, the data significant more events in the group that were treated with insulin. And this is what the echocardiographers see all the time in hypertensive patients, in diabetic patients, diastolic dysfunction. I don't want to spend too much time. This is important. We see patients with angina or with chest pain, and we know there is no epicardial disease. Well, 1/3, the problem is non-cardiac, whatever it is. The others may be cardiac, the other 1/3, whether it's pericarditis or something else. And here, about 1/3 is the microcirculation. This data is based in our experience of how often we see patients with trouble of the microvasculature, particularly when we use MRI as the test to assess it. Ischemic cardiomyopathy, diabetes, obstructive sleep apnea, dementia, probably because they have the same problem in the microcirculation that I mentioned above, is also in the heart. And this is amyloidosis. You have all of this. This has not been published by us. I only outline the thing that we see in daily practice, that we became aware with the new technology that we might be facing a problem of this large surface. I'm going to finish, and I'm going to make the following points. The first point is there is a lot of irresponsibility here. And unless we put ourselves together, we are not making a good progress. The disease is not being preventive. We are not going into the younger people. When we talk about subclinical disease, we don't care. In fact, we believe that we don't feel vulnerable. We are not able to fight the politicians, we are not able to fight the tobacco companies, and there are a lot of talkers in the field. And on top, air pollution is for some people who talk about climate, and when we talk about climate, we really don't know what we are talking about. There are lots of things that we are breathing that is a huge problem today. That, to me, is what I feel we should fight, and that's why it's the word resilience. The issue of subclinical disease, I am just tired of people who write abstracts and papers. I see this in JAC. They write, but there is no message. I detect this and so forth. We have to go much further. The microcirculation of the brain has to be addressed from the research point of view. The subclinical disease with 3D ultrasound has to be addressed clinically. The microcirculation, we have it in front of us every day, and we see it, but we still bypass lesions that have nothing to do with the syndrome. These are 3 challenges. But the question is, once we understand the microcirculation of the brain, the microcirculation of the heart, and the relation with the risk factors with the large arteries, what do we do? And I'm not going to get into any details, but you know very well that in the last 3 years, I have been obsessive working in the area of promoting health. And very basically, we are doing in the elderly, we are doing in middle age, with techniques like Alcohol Anonymous, group therapy, like getting into the individual, creating a culture, as we have done in Kenya with hypertension, and now we are doing in Madrid. And we are getting into children between age 3 to 6. Do you know how many children we are working today? 100,000. They are following the program between age 3 to 6. That is the opportunity. These children actually have, the centers of the brain are not connecting. So they capture everything you tell. At age 10, everything gets out of control. Because there are lots of connections, there is puberty and so forth. The age 3 to 6 is the huge opportunity that we can at least begin to talk about promoting health. And this is basically what we are doing. I didn't present a single slide today of this, but we feel responsible that we really have to go to the roots of the problem. And the roots of the problem are behavior. I always tell the students, I started 3 years with a PhD thesis studying platelet factor 4 coming out for the platelet to see if a clot was the cause or the consequence of a heart attack. This led me to thrombosis. This led me to atherosclerosis. This led me to begin to understand atherosclerotic disease, led me to the imaging. And from the imaging to the risk factors. And finally, at the very end, I realized that the whole problem is in the head, is our behavior. So what I'm really presenting to you is a reality of the future. Today, I just did a snapshot of an aspect that is presently very important, and that is, can we identify who is developing the disease, and can we do anything about it? We started with the children in Bogota, we went to Madrid, we did the project of blood pressure, how we can get into an individual and create a culture in the environment in Kenya. Then we went with the group therapy in Spain. The TAN-SNP, I mentioned this, we are getting into the brain. Now we are working with the families in Harlem, the children, 6,000 families in which we are talking about the issue of the children and the parents. The parents are between age 20 and age 35. We are studying genetics, imaging, and so forth. And finally, we are in a city, the town of my wife, which we are now working not on all the projects I just mentioning, but in addition, we are creating pathways for people to run, a new soccer field, and then an auditorium that will only be devoted to education in health. And in fact, I can give you already a snapshot. Those of you who used to come to Cardona many years ago, is going to start again. And it's going to start again next year with a new auditorium. And in the auditorium, we will not have rock stars. The auditorium will be only, absolutely only, to teach health. And the concept is, can we make a city healthy? And then this concept to be transferred to more general. Well, I finish by giving thanks to you for this opportunity. And obviously, I cannot get away from the fact I feel very emotional when I see the picture of this lady. She was absolutely unique. Thank you very much for your attention.
Thank you, Dr. Fuster, for your inspiring lecture. I think this made us all reflect on the way we are approaching cardiology at the moment, and I hope that we will be up to this huge challenge that you just exposed to us. And now, it is my pleasure and my honor to have Dr. Fuster and Dr. Rosa-María Lidón and myself that we will be able to present Magda Heras' family, her husband, daughter, and sisters, with a small token of appreciation and love from the working group on ischemic cardiac disease and acute coronary care.
Well, it's a pleasure to give this to you on behalf of the Society and of the section of coronary ischemia, and we are all very pleased. So my job is to give it to you, but they have done the work, and thank you very much. Us deia que us volia donar les gràcies per aquesta oportunitat i vull fer això en nom de la Societat de Cardiologia i concretament de la secció d'Isquèmia.
Well, I had the privilege of being married to Magda Heras for 38 years. And I can promise you that if there is one statement that's 100% true, that statement would be Magda Heras was proud of having been president of this section. She was proud of being cardiologist. She was proud of being among you. It is now 20 months since she passed away. It was a warm but beautiful evening, summer, when she closed her eyes forever. 20 months of kind words, 20 months of shared friendship, of emotional encounters, but above all, has been 20 months of realization of how important she was to all of us. And that includes you, that includes this section. Thank you very much. So on behalf of the family, I want to express my deepest gratitude to the organizers of this memorial, to my wife, to your mother, to our beloved friend, and to a doer, not a talker. Thank you very much.